We are witnessing a rapid growth of the use of AI in the healthcare profession. The key question is, can you trust Dr. AI? Which is the theme of the scientific session, which Dr. Win Cerf, Chief Internet Evangelist at Google, and I are organizing. Hello, I'm Ram Shriram from the National Institute of Standards and Technology, and I am the moderator for this session. Thank you for joining us. The presentation is one of three pre-recorded videos focusing on a speaker's material before all the panelists come together in February during the live discussion. In this video, Adewole Adamson, also known as Ade, Assistant Professor of Medicine in Division of Dermatology, Dell Medical School at the University of Texas at Austin, will be discussing how machine learning can't solve the gold standard problem in cancer diagnosis. Will be followed by Dr. Nageshwar Reddy, Chairman and Chief of Gastroenterology, Asian Institute of Gastroenterology, India, for further discussion.
Thank you for having me at this session where I'm going to talk to you about how machine learning can't solve the gold standard problem in cancer diagnosis. As a matter of disclosure, I'm a member of the American Academy of Dermatology's Augmented Intelligence Task Force. Anything that I have to say here are my opinion and my opinion alone, and not the opinion of the American Academy of Dermatology. Machine learning has a lot of promise as it relates to cancer diagnosis. One of those promises is the delivery of faster diagnoses. Machine learning enabled technology could truly revolutionize the speed at which we can render diagnoses for patients with cancer, which is a good thing. Machine learning also has a promise of increased reproducibility. So rendering diagnoses to patients that are consistent, right? Consistency of diagnoses has been a problem in healthcare. So one might ask, how can this be a bad thing in cancer? And so I'm a dermatologist. So most of this talk is going to center around one type of cancer that I deal with on a regular basis called melanoma, which is a potentially deadly form of skin cancer. If you look at the epidemiology of melanoma, here you're looking at its trends in incidence and mortality over time. The incidence, which is the number of new diagnoses, has increased dramatically, but mortality, which is the death rate, has remained flat. Melanoma incidence has risen sixfold in the last 40 years. Once a rare tumor, now in the United States, melanoma ranks as the third most commonly diagnosed cancer, just behind breast and lung. These epidemiologic features you see here are concerning for something that's called cancer overdiagnosis, which is the diagnosis of lesions that meet the pathological criteria for cancer, but finding them has no effect on mortality. Put another way, if you see an increase in incidence, you should see a drop in mortality, which you're not seeing. So we're catching a lot of cancers that for some reason are not having an effect on the death rate. So let's delve a little bit deeper into overdiagnosis. Overdiagnosis is the diagnosis of a disease that will never cause symptoms or death in a patient's ordinary lifetime. There are two requirements for overdiagnosis as it relates to cancer. One is the existence of a silent reservoir of disease, and two is activities that lead to its detection, like screening, going to the doctor, just being examined a lot, having a lot of mammography, etc. And AI tools are posed to make detection much easier. A little more background. If the number of new cancer diagnoses were to go up, you'd expect, if it's true disease, that the number of deaths should also go up. This suggests true cancer incidence increasing, or the amount of real cancer that actually will kill people is increasing over time. But when you see this kind of figure, where diagnoses are going up and deaths are flat, that suggests cancer overdiagnosis. Now, as a dermatologist, I was picking on melanoma, but there are other cancers out there that have epidemiologic signatures suggestive of overdiagnosis, thyroid cancer being one of them. kidney cancer being another one of them. And as I said, melanoma is also one of them. Even in breast cancer, the introduction of mammography led to a huge increase in the amount of breast cancer that had been detected, but the amount of late stage breast cancer hadn't changed in this period over time. So again, suggestive of you looking harder, i.e. through mammography in this case, for cancer, you'll find things that meet the definition of cancer, but actually would not have harmed anyone. Now, why does this happen? Well, let's get back to melanoma. So these are the type of specimens we used to send to the pathologists, right? And the pathologists are the people that look at cancers under the microscope, right? You can see this big dark spot that even an untrained person would probably tell you this probably needs to be checked or biopsied and looked at. But now, because we're screening people or looking at healthy people that don't necessarily have these big, huge tumors on them, we're making diagnoses on these kind of biopsies, really small, less determinate. And I want to remind you how we diagnose melanoma, and in fact, many different solid tumors, has not changed much in the last 100 years. We do a biopsy, we fix it in formalin, and then we have a pathologist look at it under the microscope to make a determination whether this abnormal grouping of cells is something that maybe in the future, if not treated, would be destined to metastasize and kill someone. Now, there's a problem with how accurate or how reproducible pathologists are with their diagnostic rendering of melanoma. In this study in the British Medical Journal, the accuracy of 187 pathologist interpretation against a reference standard revealed that there was little agreement, right, of individual pathologists as compared to a reference standard in diagnosing early stage melanoma, i.e. melanoma in situ, or thin melanomas, right, versus them being not cancers. And now, if you give that same set of 187 pathologists the same slides 8 months later, their ability to reproduce these diagnoses are extremely low, right? So pathologists can't even agree with themselves of what they've decided is a cancer versus not a cancer. Even if you look at expert dermatopathologists, right? So these are people that specifically look at skin lesions. They can't even agree what a melanoma is. In this classic study from 20, 25 years ago, the National Institutes of Health, they convened a group of 8 pathologists, all experts in skin cancer, and they asked them to contribute 5 skin biopsies that he or she considered classic for either a melanoma or not a melanoma, okay? 37 specimens were collected and they were stripped of all identification, and each pathologist was asked to render a diagnosis of cancer versus not cancer. In 13 of those 37, they agreed on what was cancer versus not cancer. On the rest of them, or the majority of them, complete consensus could not be arrived at. And this is complete consensus as to what is a cancer versus not a cancer, or a melanoma versus not a melanoma. So again, expert dermatopathologists can't even agree what a cancer is in this situation. And over time, dermatopathologists have started to call things that used to be not labeled as cancer. This is a study of 40 biopsy specimens originally read in 1990, and then they were read 20 years later by 9 dermatopathologists. And over time, the risk of you being downgraded from a melanoma to a benign lesion was very low compared to you being upgraded from a benign lesion to a melanoma lesion. Basically, what this figure is showing you is that the threshold for calling things cancer has also been changing over time. So this is what we call the gold standard problem in cancer diagnosis. And for artificial intelligence driven technology, it will run into some problems where there's uncertainty around what is a ground truth. And the reason for this is because a lot of the technology that's being developed using supervised machine learning is based on an external standard, which is the pathologist's interpretation of what is a cancer and is not a cancer. So whether that's the label training set data, the test set data, or the additional training, all of these gold standard labels are being based on a problematic external standard, right? And so if you were to empower a algorithm based on this flawed standard, you could actually worsen the issues around overdiagnosis that I talked about earlier. But one way in which AI could help with the gold standard problem is by putting guardrails around our uncertainty. Let me explain. You could label a set of lesions, right, that all pathologists agree are cancer and all pathologists agree are not cancer, using, say, a group consensus. And those in the middle, those that are discordant, perhaps you could study those tumors. You could offer conservative treatment, so not as wide of an excision, as an example, for melanoma. And you could also observe these lesions. And I would say that this would make our ability to treat patients actually even more difficult, because you can imagine an AI technology that would be able to triage all of these simple cases that are clearly cancer, clearly not cancer, and leave these more intermediate lesions for the pathologist to focus his or her attention on. And I know a lot of physicians feel as though this kind of technology might replace them, but in fact, I think actually the opposite. And this is a quote from Ledley and Lusted, who launched the kind of informatics and clinical decision making fields. And this is what they said in 1959. I think it still holds today. That this method in no way implies that a computer can take over the physician's duty. Quite the reverse. It implies that the physician's task may become more complicated. The physician may have to learn more. And I think that's where we're headed. And I would like to thank everybody for listening, and those that helped me with my research, including my funders. And I'll take any questions.
Thank you, Adi. Now Nageshwar will join the conversation. Welcome, Nageshwar.
Again, like to thank AAAS for this opportunity. And Adi, that was a fantastic talk. I think it was very clear on what you wanted to say. So one of the problems with biological systems are that they're very complex, and it's very difficult for a simple AI sometimes to discern what is right or wrong. And even for human brain, which is trained over a long period of time, some of these indeterminate cancers become very difficult to get a, say, for example, the kappa factor between different observers are totally variant. So I think this is a problem we have. So I was thinking that in AI, of course, we can say clearly whether you're having a cancer or not a cancer, but these indeterminate or difficult cases can go more for the pathologist or the clinician to see and make a definite diagnosis. I was wondering whether we should concentrate with AI rather than this basic diagnosis, whether we should concentrate on more complex problem. For example, increasingly it is known now that the prognosis and the type of chemotherapy we use in our patients, the type of treatment we use in our patients with cancers are determined about on the somatic mutations that you see in the tissue. And this is an example with pancreatic cancers that we deal in my specialty. You not only take these cancers for biopsies, but we also do mutation studies on them. And based upon the number of mutations, different types of mutations, you could actually prognosticate and decide what type of chemotherapy to give. Now, this can become large amount of data that we have. And this large amount of data sometimes becomes difficult for the human brain to sort of analyze, put together, and so on. So I was thinking maybe artificial intelligence may be more useful at that level, where we have a large amount of large bits of information that we put together, and then you can come to a conclusion saying that this particular patient would respond to this particular chemotherapy or this treatment, and this could be the possible prognosis. I was wondering whether I can get your thoughts on this.
I think that you bring up an excellent point, that we need to focus on the areas of strength that AI can potentially, bring, which is the ability to bring together and analyze a lot of data at once that the human brain can't necessarily do. And I think when it comes to genomics, that is clearly one space that is ripe for this kind of technology. But I would also say that we need to make sure that whatever outcome that we're concerned with, whether it's, chemotherapy selection or treatment regimen that should occur, that algorithm should also be powered for outcomes we care about, like overall survival, or if you want, disease-free survival, et cetera. So we need to make sure that we don't blindly follow what the algorithm has to say, but that we also study it in the context of whether it will improve outcomes or not. But I agree 100% that in some of these more complex decisions that we have to make, AI may have a real strength.
Thank you, Eddie. And the second problem, which I think is going to become a major problem as we start using AI in our routine practice, is the question of medical legal importance. For example, again, I come back to our specialty, gastrointestinal endoscopy. We now have commercially available AI systems we can attach to the endoscope. And as we are doing colonoscopy, the AI will tell us whether this is a polyp, whether it's an adenomatous polyp, whether it's a hyperplastic polyp. Now, adenomatous polyps need to be removed. Hyperplastic polyps can be just left alone. Now, what happens if when you're doing this, the AI makes a mistake, or at least is a difficult case where the pattern recognition is not proper, and you get to diagnose adenomatous polyp as hyperplastic and leave it alone, and the patient comes back later with cancer. There's, of course, the medical legality involved in this. So who should take the medical legal responsibility for this? Is it the doctor using this, the AI system? Then it becomes very complex. I think this is an issue that we have to resolve before we start using AI in our routine practice.
Yeah, I agree totally. That is a very fundamental issue that needs to be resolved. And the corollary is in melanoma. It's a funny looking mole that you decided to use your AI equipped cell phone to decide whether she had biopsy or not. It incorrectly says that it's not a melanoma or a melanoma precursor, and the person ends up with metastatic melanoma. I mean, that would be the feared bad outcome. The way I think about it medical legally, because we haven't figured this all out yet, I look at autonomous vehicles, right? And whether you using cruise control, like say in a Tesla or one of these fancy cars, whether Tesla should be at fault for the crash versus the driver that was asleep at the wheel or eating or doing something else. And I think that it'll be difficult for these technologies to move forward if we put the onus on those tech firms or companies as being at fault for getting the wrong diagnosis. And I think that ultimately it needs to rest on the physician, right? And appropriately using this technology and not basically using it as a crutch to supplant his or her clinical judgment. And I think that's also important from a self-preservation standpoint as well. We as physicians, I think, need to also be the ultimate arbiter of, what is the correct treatment versus not, right? And not cede it completely to a computer, because after all, I still think that there is some art to medicine, and that it's about the doctor-patient relationship, and this technology should be seen more as augmenting that versus replacing it.
I absolutely agree with you, Adi. Thank you for this. I think these technologies are coming. Artificial intelligence is going to play a major role in future in medicine, both in diagnosis and treatment. But as you said very critically at the last point, that it's very important. The art of medicine is not lost on us. Medicine is still, I think, something which is not just science, but there's an art in it. And even the science of medicine has a lot of variations based upon, I think, different areas where you're practicing. And I think individual patients vary differently. So we still have a role as doctors, but I think in where a lot of information is required to be processed and acted on, or where you require a consistency on some particular problem, this is where I think AI is going to come in future. Thank you very much for your very nice talk.
Thank you again, Ade, for your remarks, and Nageshwar for joining in. This has been a remarkable discussion between two world-renowned experts in the medical field. Just a reminder, this is but one of 3 spotlight videos focusing on the individual work of the speakers before they all come together in February in the live panel, Can You Trust Dr. AI? We are currently scheduled for February 8th, 2021 at 1 p.m. Please check the AAAS annual meeting website for any changes or updates. Again, thank you, Ade, Nageshwar, and you, the audience. And we will see you live in February. Thank you.